Welcome again, everyone. For those who have just hopped on, you've found yourself in the Life Unites Us webinar on mixed messages and mixed results, how structural stigma undermines treatment and recovery. Please continue to introduce yourself in the chat box. We love to see who's joining us today. So feel free to share your name and your organization and why you've just decided to join us today. We're excited to hear from you all and also from our guest speaker. So we will get started here today. On the screen now is our agenda for the webinar for this session. The webinar will last about an hour. So to kick things off, a few quick housekeeping items. As a participant on the webinar, you will not be able to speak to the group or share your video. However, we'd still love to hear from you. So if you have any questions for our presenter or for me today, please make sure you add them to the question and answer function at the bottom of your Zoom screen. We will save time at the end to review some of these questions. We will also be recording today's session. It will be available to view and share after the presentation, and we'll make sure that the slides are included there as well, so you can continue to learn from all of the information that will be shared today. Today's session is unfortunately not transferable for CEU credits. However, we can provide a certificate of attendance by request. So just email info@lifeunitesus.org to get a certificate. Last thing, there will be a survey link sent to you at the end of the session, and we'd love your feedback on this webinar and also suggestions for future webinars. So please make sure to share your ideas when that pops up at the end. And now that we have those housekeeping items settled, we can jump into the session. I'd first like to introduce myself. My name is Maddie Morales, and I'm part of the team working on the Life Unites Us campaign to reduce stigma around opioid use disorder. I work for the Public Good Projects, and we are a nonprofit public health communications organization dedicated to developing behavior change campaigns. My role on this team is to engage community organizations in this effort. So I'm especially excited to see so many of you on the call today from lots of different community organizations. We know this work is worthless without all of you. So thank you for being here. I would also like to quickly introduce the Life Unites Us campaign for those who are new or just need a refresher. Life Unites Us is a project. It's a social media campaign developed to reduce stigma around opioid use disorder. We do this by using a people-forward approach that aims to connect individuals through stories. Through our research and practice in anti-stigma work, we have found that connecting people through their stories and similarities can and will reduce stigma. So in order to do this, our team records stories of community members across Pennsylvania, stories of both personal recovery or as an ally to someone in recovery. We then produce these short videos on our website and social media to be shared far and wide. Our intent is that by sharing stories of hope and resiliency, we can prove that recovery is probable, reducing stigma makes recovery more likely, addiction is treatable, those living with an addiction are just like everyone else, and those living with an opioid use disorder are so much more than their disease. So we're excited to have you join us for that in that effort today. And this is a slide where you can see what our campaign actually looks like online. You can find us on Instagram, Twitter, Facebook, and of course on our website. And we encourage you to take a look at those places and listen to those stories. Feel free to follow and share. There's both stories, the videos, as you can see, and also just messages to fight stigma. This project is a partnership between Penn State Harrisburg, the Pollock Center, Shatterproof, and the Pennsylvania Department of Drug and Alcohol Programs and the Public Good Projects. However, we recognize that in order for this effort to be truly successful and sustainable, we need community organizations like yours to join in the conversation as well. We are currently working alongside 65 partner organizations across the state of Pennsylvania and welcome you to join us. Some of our partners are listed here and many more are on the call today. Hello. But our aim is to provide a platform for voices from your community and a resource to add to the work many of you are already doing to end stigma. So as a partner with us, you can join us in ending stigma by amplifying the campaign to your community. And partners of the campaign have the opportunity to help us both recruit stories and share those stories to and from your community. As a partner, you'll have access to exclusive partner resources and stigma fighting messages. You'll have your logo included on our website. You can share your feedback to help inform the direction of where this campaign goes next. You can help us recruit stories from your community, and you can also get connected with our statewide network of partners. So if you're interested in all of that, we'd love to hear from you. You can complete the form on our partner page or just send an email to my email, which is listed on this slide here. All right, well, with all of that, I am very excited to introduce the meat and potatoes of our presentation today. One of these partners that I mentioned is here to speak to you all on the subject that you signed up to actually hear about. So welcome to Brad Sorte from the Caron Treatment Centers. And I just want to share a little bit of background about Brad. Brad's the incoming CEO and president of the Caron Treatment Centers, and will be presenting today on how structural stigma undermines treatment and recovery. In his current role, Brad oversees the operations of the business development, marketing, and admissions departments, and is responsible for aligning strategy and performance for Caron Treatment Centers. His previous experience in business and clinical leadership as the executive vice president and managing director of Caron's Florida Continuum continue to inform his work. He remains committed to his goal of providing a culture in which the business of healthcare never interferes with the fundamental needs of each individual patient. Brad began his career at Caron as a family therapist at Caron Renaissance and then a primary therapist at Ocean Drive. And in those positions, he facilitated client group sessions, family workshops, and the residential family program. Drawing from that experience, Brad believes that for the best chance of success, each family member must participate and feel supported in the healing process. Playing a significant role in addiction and behavioral healthcare, Brad speaks at conferences in the US and abroad on topics ranging from family recovery and young adult addiction to the changing landscape of behavioral health. He has been featured in the New York Times and Miami Herald as well as various media and industry publications. Brad holds a Master of Social Work degree and a Master of Business Administration degree, both from Florida Atlantic University. He earned a Bachelor of Arts degree in psychology from Rice University and a Bachelor of Science degree in legal studies from Kaplan University. So we are so grateful to have Brad joining us today. And I will pass it over to him to get started with his presentation. Thank you, Brad.
Great. Thanks, Maddie. Thanks for the introduction, and thanks to the Public Good Projects for bringing this really important topic to our industry community here. So, really what we're going to talk a bit about today is how the existing structural stigma that is present in the treatment industry, in addiction and in recovery, continue to create some confounding effects that undermine both the efforts that we are trying to do on the treatment and prevention front, as well as the individual efforts that each person trying to get into recovery can overcome. It's not all bad news. I mean, there's actually some light at the end of the tunnel and some reframing that we're going to spend some time talking about. But if we go to the learning objectives, I'll kind of highlight a little bit about what our agenda is today. And we're going to spend some time talking about some definitional things, just in terms of what is structural stigma, how does it show up in various points in the treatment continuum, talk a little bit about the history of the treatment model and how the treatment model historically has created some of those challenges, and juxtapose that against what key elements for high quality care, reimbursement models, and talk a little bit about how we can continue to move towards really approaching the treatment of substance use disorders from an individualized perspective, and really looking at that as the management of a long-term chronic illness. I think the next thing we'll do is we'll go to a little bit of a definition of what are the different types of structural stigma on the next slide. And really go back one, please. There you go. Lots of information on this page, and I'm glad that this will be made available to everybody following the presentation. But we really looked at this as kind of breaking down the different forms of stigma falling into three broad categories: societal conditions, cultural norms, and institutional policies. And the reason we really wanted to look at this through this multi-dimensional approach is that really the remediation of each of these things requires a different mindset and a different approach. But when you see all of the different factors here that are contributing to the perpetuation of stigma, you can see just how baked into our society these things are. And I'm going to highlight a couple of these things. We're just to look at the societal conditions first. For 1 second. Go back one. There we go. Thanks. Things that we are probably pretty familiar with: economic inequality. The options for people who are seeking treatment vary widely based on their ability to pay, ranging all the way from people who are on government-funded insurance to people who have the ability to pay privately or have good private insurance. There's criminal justice implications, both that show up in the societal conditions as well as in institutional policies. And there's also some misunderstandings about drug use, drug treatment, and recovery that tend to perpetuate some of these things. One of the things that I think is a significant barrier for us to be overcoming has been this very binary way of looking at people's success in overcoming a substance use disorder, i.e., either somebody is able to get into lifelong remission without any reoccurrence of symptomology over the course of time, or if they have a reemergence and that kind of being seen as a failure. And as a result of a lot of these things, there's a tremendous amount of shame and embarrassment associated both with the acknowledgement that someone may have a problem and even a significant amount of shame and embarrassment when considering going to treatment. We're going to go to the next slide. Opioid use disorder patients tend to have an added couple of layers of stigma associated with their illness. And I would say that if somebody really wanted to fully get a grasp of just how dire this problem is in our society, I'm sure that most on the webinar have probably seen newsreels or read articles in national news about the situation here in our backyard in Kensington, just northeast of Philadelphia. I actually had an opportunity to go there 2 weeks ago with a group that does outreach, and really you can see just how forsaken this group of most vulnerable individuals really is, and it's kind of a tragedy that it's something that we would allow to have happen in our own country with rampant crime and medical issues amongst probably one of our population's most vulnerable groups. And these things are perpetuated by barriers to getting proper care, and really a lack of consensus on how best to treat these individuals, as well as a level of a human element to that. And I think that probably one of the most stark representations of how this structural stigma really affects this group is the invisible nature through which their plight is really kind of been acknowledged by society as a whole. And so in doing so, we create this almost dehumanizing element for people who are in the most severe throes of this addiction. And again, in speaking with lots of these folks, it's usually a population that has experienced tremendous amount of loss, trauma, economic and social displacement. And so, while they may be struggling with a life-threatening illness, of opioid use disorder, and that's a primary issue for them, there's usually multiple layers of issues underneath the surface that really confound the ability for these folks to be able to access care. So with that as the backdrop of kind of the problem that we're dealing with, I want to present another side to this narrative. And so on the next slide, there are actually a few data points that I don't think we talk about nearly enough as a field. Most people are pretty familiar with the fact that at any given time, there's about 20 million, 21 million people in this country that are currently actively suffering from a substance use disorder. But what doesn't get talked about is that there's more than that, over 22 million, who are actively living in recovery today. And I think that juxtaposition is a really important one, because it tells the other side of the story, which is that while we still have a raging epidemic in our midst, and I'm not going to sugarcoat the fact that the lethality of this epidemic got significantly worse during COVID-19, recovery is possible and within reach. But this continued focus on just the negative side of addiction, of treatment failure, continues to reinforce a very negative narrative, a very negative stigma, not just for people with a substance use disorder, but just the attitude towards actually getting help and getting into recovery. A couple of really interesting data points that came from some of John Kelly's work at the Recovery Research Institute, that 75% of people who at some point in their life have meet the criteria for a substance use disorder will eventually get into long-term recovery. Again, a data point that I think most people would be surprised to hear, and certainly something that we don't talk about nearly enough. I also think another data point that came out from Dr. Kelly's research was that while the average number of attempts that somebody makes to get sober is 5, so the mean is 5, the median's only 2. And that's informative for a couple of reasons. One, it says that for many people, recovery is possible with 1 or 2 attempts to get sober. But there's a not insignificant minority of people that recovery is very much a challenge to achieve. And as a result of the multiple attempts that group needs to make, that drives up the average. So we need to have highly specialized care that identifies the fact that there is a significant group of people that will need lots of resources and potentially multiple attempts to get into recovery, but that many people, much to hopefully their benefit, may be able to get into recovery on the first or second try. I also think that another thing that we like to highlight from here is that if we're able to get people to that magic 5-year mark, the risk of someone who had previously had a substance use disorder going back to a period of active use is the same as someone who never had one in the first place. So lots of really interesting data just in terms of the possibility of recovery for individuals. And again, I bring this stuff up not to minimize the true scope of the problem, but again, it's to begin thinking about how we can be part of the solution in challenging the stigma associated with treatment and recovery. So moving on to talk a little bit about the science behind this, we know that substance use disorders are a chronic and treatable brain disease. That we recognize that in people who have a predisposition for a substance use disorder, the brain begins to function in a way that is no longer the way that the brain would normally function, by having the reward circuitry of the brain hijacked, that puts the pursuit, use, and recovery of drugs and or alcohol as that individual's priority for survival. Unfortunately, for many, many, many years, our approach to treating substance use disorders really looked much more like the management of acute conditions. Heavy emphasis on detox and shorter lengths of stay, and much less emphasis on the recognition that long-term care and ensuring that patients have access to that is something that can help keep them in recovery for an extended period of time. The next couple of slides really just talk a little bit about some of the differences between the brain response for somebody who does not have a predisposition for a substance use disorder. And then on the following slide, you can see how the response that an individual has to using a substance tends to create a vicious cycle where when originally a substance was introduced to the brain that achieves some sort of a short-term positive benefit, really we look at that through the lens of relieving some form of psychological pain, that there's diminishing returns to the point where even when somebody continues to use, they're really only trying to get back to their normal baseline. And as a result of that, there's a really negative reinforcement cycle of continued use, diminishing returns, and that person moves further and further down the rabbit hole. As we kind of move to looking at some of the brain imaging, I mean, you know, this is something that we can see in a variety of different brain imaging methodologies, whether it's through functional MRI or PET scans or even service EEG. Brain functioning changes when somebody is in early abstinence from drugs and alcohol, and even after a period of 100 days, you can see here that the brain functioning of somebody who's addicted to cocaine, you know, still isn't back to baseline. And so that's why that long-term component of care and a level of respect and understanding for people who are in early recovery is really essential to destigmatizing it, which is that it takes time for new habits to get habituated and for brain function to return to something, you know, that is more equated with normal brain function. So if we're to move on and talk a little bit about here's what I like to kind of call the treatment center sector goat rodeo. You know, we really have quite a few challenges that we're dealing with, which you can kind of see on the next slide. We don't really have historically, we don't really have well-defined and universally agreed to outcomes. We have had a slow uptake in the adoption of medication-assisted treatment, especially for opioid use disorder. And we've had this acute focus of our treatment model that has really not given our mutual clients the best opportunity to actually manage their chronic illness. I also think that the other issue that all of these things kind of come together to create, you know, really is this attitude towards treatment that people go to treatment and when things have gotten to the breaking point, which means that there tends to be this attitude towards waiting for people to, quote, hit rock bottom before something is done. And what we've really missed out on is the opportunity to intervene on people, in many cases, years, months before they develop a chronic illness, where treatment for that substance use problem that they may be having could be addressed in an outpatient or a much lower level of care. One of the stigmas that we've really seen come with that is there's an attitude towards if you are having a problem with drugs and alcohol, it's pretty easy to live in a place of rationalization, which is that it's not a problem if I'm not asking for help. But even though you may be having life problems, occupational problems, relationship problems, by not admitting that it's actually a problem, it somehow makes the problem not exist. Where on the flip side of that, somebody who decides to take a break from drinking because they feel like they've been drinking a bit too much, let's say over the past year in COVID-19, historically that decision would be viewed with an eye of skepticism. Peer group, friends may look at that and say, oh, are you an alcoholic? So we haven't done a really great job of making it a supportive environment for people who are curious or concerned about their drug or alcohol use to do something about it until early on, as opposed to waiting until it gets to be a point where it's very severe. So we move on to talk a little bit about, you know, some of the challenges with standards of care. we have historically had a bit of a siloed industry where you have multiple approaches to treating substance use disorders, but there has been a tendency in many treatment settings for the treatment to be the model and the approach that we provide. And it may have a heavier emphasis on certain aspects of care, and it may not even include others. And as a result of that, if I end up in a program that doesn't necessarily have some of the modalities that would be a great fit for me, I might have an unsatisfying or an ineffective outcome. And I think probably one of the great and simplest examples of this would simply being, somebody who has an opioid use disorder, goes online, gets a referral from a friend, goes to a particular treatment center, makes the time and financial investment to do so. Maybe they go to a treatment center that doesn't do medication-assisted treatment. And this may be an opioid use disorder patient who has a long history of relapse, including potentially near fatal relapses, and as a result would be a great candidate for that as an adjunct to their care. But if that treatment provider doesn't have that as part of its philosophy, they're going to be missing out on that. They may have a negative outcome. They could die. If they don't die, they certainly could walk away feeling that treatment doesn't work. And so that's why there's a tremendous amount of responsibility on all of us to really be very patient-centric and recognize that there are multiple ways for people to get into recovery, and there's multiple trajectories that recovery can take. Being sensitive, being focused on the individual and what their needs are is something that we really need to do. And again, there's a lot that we can draw from the rest of the healthcare system that shows us that if somebody is going in for treatment for cancer, if somebody is going in for treatment for diabetes, if somebody is going in for treatment for cardiovascular disease, the treatment approach that is going to be prescribed to that individual really is going to be very individualized based on them, their other health circumstances, and what is going to give them the greatest likelihood of success over the long run. So if we're kind of looking at what some of those components might be, the kind of components of comprehensive care, it's really recognizing that an individual suffering from a substance use disorder is dealing with a multi-systemic illness. Usually the substance use disorder is what gets somebody through the door to get treatment because it is highly energetic, meaning that it's visible. You can see it happening. You can see and feel the tangible connection between a continuation of those behaviors and a very possible outcome of death or serious harm. But if you were to peel back the onion, in most cases, you're going to find that they are dealing with issues really in all of the dimensions that are kind of surrounding the blue circle here. They're having issues with job. They're having issues with the law. They're having financial issues. They probably have underlying mental health issues, which is something we'll talk a little bit about. But there's a saying kind of in treatment that, the days of kind of the quote garden variety alcoholic coming through our doors, really have kind of gone by the wayside, that the average patient presenting to substance use disorder treatment tends to be quite complex. And so if the treatment approach isn't looking to both assess on a continual basis and direct treatment planning activities toward remediating all of these issues, recovery is going to be more of an uphill battle, because all of these social, biological, psychological, and emotional elements can either serve to be foundations for a life in recovery or barriers to recovery if they're not addressed. The Recovery Research Institute does a nice job of outlining some components of quality care on the next slide here. And so, I find this to be a great infographic, because it's simple enough that for, a non-industry experienced person or to the consumer, it kind of gives them a litmus test of the things that they need to be looking for as it relates to vetting a treatment center, but things that we really think are really important and are questions that people should be asking when considering where they might want to send a loved one is, what really is their approach to continuity of care and do they have a philosophy that looks at what the levels of care and the program trajectory will be following kind of the initial phases of detox and residential. It's also critical that they have some component of assessment and treatment for medical and psychological comorbidities and co-occurring disorders, as we see that many people presenting to substance use treatment are dealing with issues in multiple systems. And really, are they taking an eclectic approach to their clinical programming that is going to be able to deal with the underlying issues that an individual may be dealing with, i.e. trauma, family issues, and doing that in accordance with evidence-based and best practices. As we kind of just looking a little bit about kind of what's going on in the brain, we really are looking at addressing multiple parts of the brain when we're putting together a comprehensive treatment plan. So we're looking at things that are much more of a higher order, and looking at things like executive functioning and decision making, utilizing talk therapy, group therapy, psychoeducation to help enhance an individual's ability to make planning and thoughtful decisions about how to manage life without substances, and then also looking at medication to target some of the more primitive parts of the brain to reduce cravings and somewhat break that short-circuited and hijacked reward pathway, so that somebody has the ability to kind of buttress their decision making with reduced cravings and less of a pull towards drugs and alcohol. As we kind of look at some of the co-occurring issues, and I think this becomes a critical element in the stigma as well, is that nearly half, just under 40% of the 20.3 million adults with a substance use disorder have a co-occurring mental illness. What I can say is we have found that the numbers presenting to Caron's programs to be much higher than that, and well over 60% of people who present to treatment do have some co-occurring underlying mental health diagnosis. In addition to that, those that may not have a diagnosable condition, we're seeing a lot of co-occurring issues with trauma, family of origin issues, and things like that. And again, all these things kind of mix together to potentially create some confounding variables. And probably most importantly, that we recognize that underlying co-occurring disorders are going to present as a significant risk for relapse for people. So, recognizing the interplay between mental health and substance use disorder, and the empathy that we need to have for people who are dually afflicted is absolutely critical in breaking down stigma. And it's complicated by the fact that we are still somewhat, we still have a pretty strong societal stigma against the recognition of mental health conditions. So people who tend to be afflicted with both, really are kind of dealing with a double closeted issue of both shame and guilt as associated with having a mental health condition, shame and guilt associated with having a substance use disorder, and then combining those two things together, probably having a malaise that's occurring in their life that just reinforces a lot of that. So there's a lot of reinforcing elements that kind of keep people stuck in this very negative mindset about their state. I want to talk a little bit about medication assisted treatment. This is actually a very interesting phenomenon that it took too long for this to really get the traction that was necessary. But what we found was that, especially for opioid use disorder, the most important thing, really, first and foremost, is to make sure that people aren't going to die. That once we've ensured that somebody is not going to die, then it's about how do we get them into making some headway in other areas of their life, and maybe even beyond that, getting them to a point where they're able to remain abstinent without some sort of additional medical intervention. But we just saw over the past 10 years, and the numbers really speak to this, that the potential of a lethal overdose has gone up just alarmingly. And put it in context, just this past year in 2020, there was nearly 90,000 American deaths as a result of drug overdoses. The previous high watermark was in the low 70s, where we had kind of plateaued from 2017 to 2019. So really a distressing increase in this past year. And again, not totally surprising given all of the stressors that came out as a result of COVID-19. But nevertheless, this is a life-saving intervention that prevents relapses. It saves lives, and if somebody is able to be alive, we're able to help them prevent relapse. Then that allows us to work on how do we get them to where they want to be. But the stigma around the use of MAT, and that, for individuals who are on medication assisted treatment having some sort of less than type of recovery than those that don't, really is a type of stigma that needs to, we really need to do a great job of challenging. Because again, we wouldn't say the same thing, for someone who, was on insulin replacement therapy and they had diabetes versus somebody who was able to manage their diabetes just through diet and exercise. We want to make sure that we're dialing up the right treatment approach for the person, and that if we're able to get them to a greater level of functioning, then that's what we should be looking at as a success. We need to look at our payment models as well. To some degree, there's a conversation around, is it the chicken or the egg? What came first, the treatment model and then the reimbursement model followed, or is it the reimbursement model that's kind of, leading the treatment model? But, whichever came first, the reality is where we're kind of sitting now is largely treatment is something that has heavy reimbursement for acute and episodic issues, detox, first stage residential. But let's go to the next slide, Maddie. Thank you. But we have had a few positive things and some challenges that have come out from the past decade as a result of the Affordable Care Act and the parity laws, which was, prior to all of that, there were very limited benefits for people to be able to receive services for behavioral health. Following the passing of those laws, there was a huge expansion in the availability of resources for people. However, we didn't necessarily have the ability to put together the structures, the consensus outcomes and approaches that we would have in other parts of healthcare. And as a result of that, the variance between a great program and a lousy program was pretty high. We also found that there was, challenges with things such as low barriers to entry. So people were able to open a treatment center with far fewer hurdles and quality control checks than you would have to open something like a hospital. And I think there was actually a really great and somewhat sad comparison that Marvin Ventrell, the CEO of the National Association of Treatment Providers, made, which is in many states, the process to go through to get a barber's license is actually more comprehensive than the licensure process for a treatment center. So, quality control became a big issue. And as a result of that, and a lot of the negative press associated with the bad actors, we had insurance payers that were skeptical about the efficacy of one level of care to another, no real outcomes for them to be able to evaluate one program over the other, and a lot of bad actors that kind of came into the space, which created quite a few challenges. I'm going to kind of just, breeze through the next couple of slides here because I want to make sure we have time for some questions. But again, just some additional background here on the reimbursement models. But if we could go to the next slide, I want to talk a little bit about outcomes and really, what the possibilities are. We were able to actually do a pilot program with one of the insurers here in Philadelphia that we did an in-network contract at a case rate with them. What we did is we set it up as a value-based agreement where we would take the risk on if somebody needed to go back to treatment, that being at our expense. But the trade-off was that we would not have to deal with managed care. And we were really pleased to find that folks coming through that program had a readmission rate to any facility, any level of care, not just having to come back to Caron, that was 2 to 5 times that of other programs. So the reality is that there is a way to do this that actually enhances long-term outcomes for individuals. It also saves a lot of cost for the consumer and for the healthcare system and the payer as a result of reduced healthcare costs. And most importantly, these things are related to improved quality of life. If we can get people into recovery, then there's a really positive effect of really enhancing all of the activities that they are involved with. Some of the public policy attitudes that I think are continue to be some barriers we have on the next slide. Are a lot of the next slide after this one. A lot of the negative externalities associated with substance use disorder, so crime and violence. We also have historically for the past 50 years or so had a very criminal justice penalizing approach to the disease of addiction, and unfortunately that has largely impacted communities of color and communities of lower socioeconomic status. So again, creating a vicious cycle that is very difficult for people to break out of. A couple other points, looking at kind of the challenges in the siloing between the rest of the healthcare system and substance use treatment. Substance use disorder treatment prior to the Affordable Care Act and the parity laws really was kind of a bit of a backwater. It was forgotten and didn't really have much attention paid to it. And as a result of that, things like addiction medicine as a specialty in medicine are relatively new. The number of research training affiliations between freestanding addiction treatment centers, academic institutions, and teaching hospitals are limited. And as a result of that lack of integration, there's just fewer people getting the type of training that are needed, who are going to be our frontline healthcare workers. And there isn't as much research going on as there would be in other disciplines. And so that continues to create a bit of a blind spot in our medical community, just in terms of how to assess, how to treat, and how to refer these clients. And as you can see, there's a bias towards a negative perception of individuals who do have a substance use disorder in the medical community. The last things that I want to talk about is real quickly is just how do we reduce this? And it's pretty simple in terms of what the broad strokes are. But we need research. We need to recognize that this, like every other discipline in healthcare, is a critical area where we need to both research the implications of substance use disorders on the individual and society. We need to gain a better understanding of the factors that can help us prognosticate who is at risk for those who have already developed the disease. How can we better prognosticate their risk for relapse and intervene on them early? We need to continue to move towards a payment model that reimburses and rewards facilities and programs that keep people from needing to go back to treatment. And in doing so, really focus on a long-term disease maintenance model like we would with any other chronic illness. The last point on here is really the last point that I want to make is, we got to change the way that we talk about this illness, because I think that the challenge that continues to keep coming up is that the reemergence rate for symptoms for most substance use disorders, and certainly on the whole, is not that different than it is for the relapse rate for other chronic illnesses like hypertension and diabetes. Yet we tend to have a very, very negative narrative around the fact that 50%, 60% of people may need to have another intervention because they have a reemergence of use. If we can begin to change that and normalize that as part of the disease, and instead focus on how treatment needs to be tailored to affect those individuals, we can go a long way to reducing people's aversion to, taking proactive steps to do something about a substance use disorder. So I am 1 minute behind what my allotted time for the presentation. So I apologize that I flew through that, but I'm glad everyone has the slides. And Maddie, I will turn it back over to you to take any questions that came through.
Thank you, Brad. That was amazing and perfect timing. That was some really great information there. So thank you for such a comprehensive overview. So now is question and answer time. Feel free to throw some questions into that chat box and we can address them. But to get started, one of the first questions that came through was about a fact that you shared at the beginning around, there was a 75% number of folks that are in active recovery. And the question is that for opioid use disorder specifically or substance abuse in general?
Substance abuse in general, and it includes people who got into recovery without any intervention, treatment, or outside resources. So it's a very broad population. So, I that's part of the reason why I give the other data in there about the mean and the median number of attempts, is because, that it really helps us recognize that on a continuum, you have people who are going to have, for lack of a better terminology, an easier pathway to getting into recovery. But we also have people who are going to be, greatly challenged because they have few protective factors, they have, different genetics. So that number really is looking at that whole group. But within that group, there are obviously going to be some groups that are going to, have a lower rate.
Got it. That makes sense. Also, sort of in that same vein, a question we had from the registration was, does stigma in SUD lead to relapse or to use again due to stigma?
Yeah, I believe that it does, and I can give you a couple examples of how I think that it shows up. One would be, one which is a really tangible one is, the criminalization of drug use. So an individual who has a conviction on their record for simple possession, that person, will have issues getting a job, have issues getting an apartment, have shame associated with every time they have to, acknowledge that they had a criminal offense. And again, that shame, that guilt, that kind of re-traumatizing experience of feeling like an outsider can create a risk of relapse. I think other things that come from it is if we're not surrounding people with an environment that embraces multiple pathways to sobriety and recovery, then individuals can find themselves feeling that they don't have a community if they're not adhering to one particular mechanism or another. So getting away from this attitude of my way is the right way, and recognizing that it's going to be different for everybody is going to be a critical one. Mm-hmm. I also think that the other thing that comes from this is, because there's so much shame and stigma still associated with not being in sustained abstinence in perpetuity, that people can begin to have problems and begin to be engaging in their addictive behaviors again. But because there's shame about acknowledging that, they don't do anything about it till a crisis really hits. So they're not proactive about saying, hey, I feel like I'm going to use or pick up, because they're afraid they're going to be viewed, through an eye of skepticism or negatively. Now, some of this is their own projections, but our projections and our self-concept is something that's also a function of how things are reflected to us. And so changing those attitudes, I think, will go a long way to reducing those stressors for relapse on people.
Yeah, yeah, I think that's such an interesting point that, we don't point a shame finger at someone that has a relapse in another health issue, whether that's hypertension or, something that is very similar. And in that vein, there's a question about: is there still a debate over whether addiction is a disease?
It's waning. I would say that it is definitely waning, but it's definitely a debate that still rages on. And the interesting thing about the debate is that the side or the folks that kind of bring up issues with acknowledging that addiction is a brain disease actually bring up some really valid points that I don't think it's an or statement. I think it's an and. And that I don't. No one is saying that the brain is the one and the only piece of the puzzle, but the brain is an absolutely critical piece of the puzzle. And so, kind of going back to one of the things that I mentioned before is, so somebody may have the brain illness of addiction, but that's probably somewhat of a lagging indicator of problems that they have that were occurring long before. Trauma, there could be underlying mental health, there could be grief and loss, there could be other situationally oriented things. And amongst those, they have this primary autonomous chronic illness as well. So, what we're hoping to see is kind of, again, moving away from this, zero sum attitude towards the definition of substance use disorders and addiction of one way is right, the other ways are wrong, is really the recognition that there's evidence for quite a few different facets of this. And there's room for all of that stuff to be included in our conceptualization of each individual case. But we're not quite there yet. And I think we still have some wood to chop.
Yeah, definitely. Is it better to say addiction is a brain disease or a disorder? And does this impact stigma?
It's a good question, I'll actually would want to kind of sit down and kind of look at the definition between the two. I think that on one hand, I don't necessarily think that addiction is a great term anymore. I think that when we made the shift to substance use disorder, I think that was a positive shift. It allowed us to begin looking at things more on a continuum in terms of mild, moderate, and severe. It kind of is looking at a combination of symptoms on that continuum, and over certain thresholds, that kind of indicates the presence of and the severity of it. And I also think that kind of the acknowledgement that I have an addiction or I have alcoholism is something that is off-putting to people. And I would say that frequently in the younger generation, teens and young adults and the parents thereof, where you have an individual who has, let's call it, a mild to moderate substance use disorder. They're misusing drugs and alcohol. There's consequences. They're doing it despite the consequences. But infrequently in those younger populations, there's a lot of other stuff going on. And I've seen parents not get help for their kid who has a drug problem because drug treatment required either implicitly or explicitly the acknowledgement that you are an addict or an alcoholic. And as a result of that, and I have a very personal example of this with a family member, as a result of that, by the time, the things came around for help for this person, the issues had gotten much more severe. So I do think that language and our definitional language is really, really, really important. And there's a lot of unintended consequences as to how we describe what's going on with folks.
Yeah, definitely. A question about MAT. When you talk about MAT, what meds are you talking about?
Primarily naltrexone or Vivitrol, the injectable version of it, buprenorphine, Suboxone, and methadone.
Gotcha. Okay. I think we've got time for one more. There was a question about why do you think the requirements or certifications for starting a treatment center were not more defined? What you said about the bar license was a bit terrifying.
Yeah. And again, each state is different. So, for example, like in Florida and Pennsylvania, there's a separate entity that oversees substance use treatment facilities versus who oversees regular healthcare. So even like here's a perfect example. So Florida is actually a certificate of need state. So if you were to open a hospital, you would have to go through a certificate of need process and then go through the Agency on Healthcare Administration process for being able to do so. The substance use facilities are actually licensed by the Department of Children and Families. And I just think that many of these agencies were not prepared for the number of providers who are coming into the space. Florida being a great example of that, where, Florida went from having several dozen treatment centers 15 years ago to having, nearly 1,000 in 2016. So I think that there was a lack of anticipation as to, what was going to happen in terms of how many providers were going to pop up. There was also a well-intentioned, although I think misguided attitude by politicians, which was, we have this huge problem and we need to get as many beds online as we can because these folks are dying from this illness, and kind of this attitude of some treatment is better than no treatment, which we have really, really pushed back against, because when we're talking about stigma, when we're talking about people having a skepticism and even an internal reluctance to get help for this illness because of the stigma, the last thing we need to have is a lack of quality control and a lack of uniformity in kind of what treatment looks like, which will just reinforce people's negative perceptions. So I think those have been two factors, and a lot of states are playing a bit of catch up now in terms of raising the bar. But it's largely understaffed agencies that really, really are trying to do the best that they can, and a misguided philosophy of let's get as many beds online as we can, without the recognition that, nobody would abide having, C- quality neurosurgery hospitals. I mean, it's the attitude should be, we want things to be of a high quality for all people. And there should be some consistency with that.
Yeah, definitely. We're still getting some really good questions in here, so I'd like to take one more. I'm just
Sure.
dropping the survey link in the chat for anyone that needs to move on with their day, but let's take one more question here. Despite the strong relationship between substance abuse and physical health, healthcare services for each of these issues are commonly provided in separate locations by distinct groups of practitioners. Patients receive fragmented care, and the lack of coordination and collaboration between systems is a major barrier to healthcare for people living and seeking treatment with substance abuse. How do you see this problem being addressed so people with substance abuse can receive treatment for the whole person?
Yeah. I mean, we are going to be having a very different conversation in 5 and 10 years from now, because this integration is happening, and I think that it's going to, on a whole, be positive for the patients, and that really is what needs to happen, both in terms of the research and training for our up and coming nurses and doctors, and really kind of looking at substance use disorder as being a critical component of their curriculum. And it's also going to be the continued integration on a practical level of substance use treatment within the rest of the healthcare system, and vice versa. I mean, it's one of the things that we've really, kind of invested a lot of our focus on is our medical facility in Pennsylvania, and the one that we're building in Florida, to ensure that people who have both health, medical, and substance use and psychological issues aren't picking, do I do this first or do I do that first? We can treat the whole person. And I believe that's going to continue to be the direction that we're going in, which will be a net positive for people in our communities.
Great. Yeah, definitely. Well, that seems like a good place to kind of wrap things up here. But Brad, thank you again. There's been a lot of praise for your presentation coming through the chat box. So people appreciated all the science and information that you shared. So thanks again.
Well, thanks for letting me join.
Yeah, of course. And to wrap things up here, I up on the slide now is contact information for how to find Life Unites Us if you're interested in getting more involved. We'd love to hear from you. And then we also hope to see you for next month's webinar. We do these every month, so stay tuned for our next one, and make sure you take that survey to help us decide what that next webinar will be about. So thank you everyone again for joining us today. And we look forward to connecting with you all again soon.
Thanks, everyone.
Thank you.